Thank you all for attending this meeting today on a Saturday evening. I would like to welcome Dr. Kirtika Rajaraman. Dr. Kirtika, would you mind switching on your video? Uh, Hi, Dr. Kirtika. She's a consultant in developmental medicine, one of the most popular developmental physicians in Bangalore. And she's also been a student of Dr. Nandini Mundukar. Dr. Nandini Mundukar doesn't need any introduction. However, for the youngsters, she's one of the senior most developmental pediatricians in the country. I think even before many of us knew what autism means or what it is, she was the person to go for autism. The next speaker we have is Dr. Chaya Prasad. Dr. Chaya Prasad is also an expert in the field of neurodevelopmental disorders and autism. She runs a center called Asha Center for Child Development and Disabilities in Chandigarh. We are honored to have you all three as speakers today. I would also like to acknowledge the presence of some other senior doctors here. Dr. Yashwant Patil. Dr. Yashwant Patil is from Nagpur, is one of the senior most pediatricians and is a very great academician, never misses any kind of sessions, is always there on time and actively participating. Dr. Priya Shivalli, I think she's driving. I don't know if you can switch on your video, madam. Dr. Priya Shivalli is the secretary of the IAP BPS chapter. Just to give you a brief intro, this is a series of webinars which we are organizing for doctors, but more importantly, it is for bringing about therapist and parental support groups onto the large scale audience so that we can have a better interaction between the clinicians and allied therapist. So with this few words, I would like to hand over to Dr. Kirtika. I would also like to mention Dr. Parmesh, who is our president, could not attend today because he's in Varanasi attending a respiratory meeting. So I would like to ask Dr. Kirtika Rajaraman to take over from here, madam. Thank you.
Good evening, everyone. Warm welcome. Happy Ugadi. So it's been a great pleasure to invite all of you for this Come Ahead series. Today, April 2nd being World Autism Awareness Day, it's a great pleasure to introduce all of you what is World Autism Awareness Day. It started around 2000 that to create awareness about autism, every year there was a theme, and based on the theme, the whole year, a lot of activities were taken up to create more awareness about autism. So when it was started in 2012, it started from creating more awareness. Then once awareness started happening in Western countries, it moved more towards like inclusive education, celebrating neurodiversity, and then to empowering women with autism. Then it became like working opportunities, inclusion in work situation. Now Western world is more towards inclusion in work situation, and post pandemic they are looking into inclusive education, post pandemic inclusive work opportunities. Now in India, where are we standing? Still there is difficulties in diagnosing, and this pandemic has created much more difficulties in diagnosing. It's not that early diagnosis is happening in India. Even now there are many children who come at 4 years of age, and this pandemic situation has changed a lot of things in the perspective of autism itself. There are many children who has not been exposed to the social world at all, and who's been locked indoors and exposed to a lot of screen. Not to blame the parents, because they have to work virtually and there is no support system, so obviously the children are put to screen. And there is a lot more newer scenarios for the pediatrician, whether to know whether is this child is having all the features of socio communication difficulties, it's because of lack of stimulation, or this child has a problem. So now we have two pioneers in the field of developmental pediatrics who are going to give us a lot of clarity on how to diagnose, how to intervene. So what is that as every pediatrician we can do to it? See, everyone needs inclusion. It's not that children with autism or adults with autism, everyone wants to be included. So where does the inclusion starts from? It starts from every individual person. So as pediatrician, how we can show is identifying each and every child as early as possible, and then motivating the parents and guiding the parents rightly towards right interventions. Right interventions at right time makes a lot of difference to these children, and this decreases a burden in the society, And there's a lot more inclusion. We can move towards more inclusive education and increasing working opportunities. Not taking more of time from speakers, it's a great privilege for me to introduce Dr. Nandini Mutka, my teacher. So she's a director of Center of Child Development and Disabilities. There's a lot of awards which has been given to her. She's been listed as one of the Indian Genius by Week magazine. A lot of peer-reviewed publications under her name. Many leading projects, many of the projects she has led. Tots Guide is one of the early developmental online portal pioneered by Dr. Mutkar. Now, let me invite Dr. Mutkar to give her talk on early identification of children with autism. Over to you, ma'am.
Yeah. Thank you, Dr. Kritika. It's such a pleasure. You know, there is a saying in Hindi, Bade Miya to Bade Miya, Chote Miya Suhan Allah. So my Chote Miya Kritika is as Suhan Allah. What else can I say about her? It was such a pleasure to have her as a fellow, and then we've become great colleagues, and so many things we can see together and do together that I can hardly call her my dear anymore. So okay, click. Okay.
1 minute, I'll share.
So I think we can, just screen share. And so as she said on the World Autism Awareness Day, it's a great pleasure to address you all and give the prospects of what I think we should have on early diagnosis. We will go through these small things. We'll talk about why is neurodevelopment important. We'll talk a little about ASD and epidemiology. What are the risk factors for you to suspect, clinical features, and if time permits, we'll just do a real problem with ASD and the role of pediatricians in early diagnosis. Next slide. Now the neurodevelopment of the brain. All of you know that the brain is highly neuroplastic. That's the most important thing for us to understand. The brain is neuroplastic right from the antenatal period to the adulthood, forming of this 1 trillion neurons, which are having 10,000 synapses each, forming and getting ourselves ready. And as they're pruning, they're also pruning as 2-3 years of age. And so that is how we get an adult brain. But what we need to understand is neuroplasticity, as we call, it was a synapses of neurons, which starts very early. It actually starts from antenatal period. What they found now is the last trimester of pregnancy and the first 2 years of life, 1,000 days as they call it. That is the first 600 and odd and 300 and odd from antenatal as the most neuroplastic period. And after that, the neuroplasticity, second thing, occurs at the adolescent period. But that does not mean that the brain is neuroplastic all through your life. And so you have great chances to make changes anytime in your life. Even each one of us have this opportunity to do this. Can I have the next slide? So this is what, just to show you that how haphazard from 36 weeks, you've seen how the growth of the neurons are, and after about 2 years haphazardly, then they start pruning. How do they start pruning? But whatever you use, the principles of neuroplasticity is use it or lose it. So the more you use the neurons, the more, and how does the neurosynapses occur? By experience. The more we work, we make the connections, not by giving instructions. So experience is the one which causes synapses, and unused neurons will be pruned away. Next. So what do we learn to know about this is what are the earlier, the vision and auditory develop very, very early. Even before birth, we start having them. You can see the slides that they are the ones which are occurring, the development occurs very, very early in them, followed by, of course, other cognition and languages all come later. Another thing very important to know is of late, we have been doing a lot is attachment. How is a child attached? Attachment bonding is called, the secure attachment, which is very required even for these children to make as much difference in their life as possible. So these three you see start so early in the first month itself. And then of course the other and emotional development, motor development all starts around first month. So you can see the 5 senses which you use along with motor are the first one to come. Cognition, executive function are all much later. But if you miss this period of neuroplasticity, we really have lost the child's opportunity to attend his maximum potential. So this is a saying that the child's 90% of the brain developed before 5 years, except the frontal lobe, all the others. So there is a saying that what happens by the age of 5 is what you will be when you grow up, for an adult. Next slide, please. So let's understand the domains of development for the pediatrician. We have the 4: cognitive, language, socio-emotional, and physical. We can see cognition and language are very much interlinked with each other. And language, of course, also has a speech, which is receptive, expressive, and social speech. Socio-emotional is again blends with fine motor, adaptive communication, and of course gross motor, fine motor. These are the domains in which development occurs. And as I go on, you will understand the value of these, why I'm putting out this, because when we do an assessment, or when we do a intervention, when we do a diagnosis, we need to know very well on all these domains where the child stands, because all development is sequential. Any domain, we cannot, if it's skip sequential, and the pediatricians normally appreciates only motor development. Is same way it is for cognition, same way for language, that it goes sequentially, and we must attend the sequence of development is important in all the domains. Next slide. So it is orderly, it is timed. There's a timing to it. That's why it's called milestones, that we have to achieve certain things by a certain age. So we do it later, then it gets delayed. If it is deviant, when something comes first, something comes second, then that's also not normal. And it occurs with predictability and regularly. And all streams develop more or less abreast. That means they overlap one another, but they're all developing at the same time. So it's a very reliable way of tracking milestones. That's what is called. Development is tracked as milestones, because we have this fact already in the brain, which is put into the brain there. And of course, we believe that an immunization and well baby clinic is a great opportunity for pediatrician to develop and monitor these milestones. Especially language, cognition, and social are very easily missed because they are not obvious to the eye. They are called the hidden developmental milestones. So one has to be sensitive to understand and want to do it, and then only can we really focus on this and get a developmental prediction done at the milestones known at different ages. Not when at 4 years the child is speaking one word. That is not saying, yeah, it's delayed. That's too late for us. Okay, next slide. Here is, I think this every pediatrician should put up in their clinic. What we have focused here is what we believe the most important milestone in autism is social milestones. And that's what is missed very, very easily. So for example, by 3 months, the child recognizes familiar faces and smiles back to the mother. Do we look for this? By 6 months, it responds to others' emotions. If you they'll make a face and cry if you shout at them. Happy when they will smile back at you. And they enjoy social games. Peekaboo, they start playing, what is called a social connection starts by now. By 1 year, they will imitate during play, like winking, clapping, and the child enjoys. This is what is social milestones which we have to monitor. By 2 years, they're very excited about the company of other children. Then they talk, they will pretend to you by, they will talk to you on the phone, like, they will do pretend play, imitative play. They point at the object, but that pointing occurs much earlier. By 1 year itself, they'll start pointing. When the visual imagery comes for them by about 9 months, they can have images of all the object. And by 1 year, you can definitely point to what they want. By 1.5 to 2 years, we'll have what is called a joint attention, that they will look at you, point, and look back at you. That is very, very important for language development. So then they will behave, they'll imitate others. By 3, of course, they are really like an adult. They'll do pretend play. They will show affection to their playmate. They can start turn taking. So if we are not diagnosing them below 3 years, then it's very sad, because many children after 3, of course, they have a full language development. By 4 years, they will start talking. They will use a pronoun. Even by 3, they'll start using I, you. By 4 years, they will talk in complete sentences. What the doctors often mistake is many times that parents come and tell us, my children can talk very well. They know everything. What is everything? They know how to say rhymes. They know how to say ABCD. They know 1, 2, 3, 4 till 20. Now, this is not language. These are all some rote skill the child has heard and learned. Okay, we can say the brain understands the words, understands that, but these are just not got any meaning in their lives. The child does not respond to the name, does not go when the parents call them. They don't have any social games. They don't call their parents to share any joy with them. Mama, see, doggy, bobo, see, they get very excited. If they'll ask for help if they can't screw a bottle or something. These are all social skills. And this is what we should look for in the very earlier years, before not 1, 2, 3, 4. And many doctors very right that child's language good. This is not language at all. Language is for social, for conveying our thoughts, our ideas, our meanings, our love, our affection. That is language. So that is what we need to be aware of. So this chart would be very useful to put it on your waiting area so parents can look at it. Next slide. Okay, next one. Hello. So what is autism spectrum disorder? With that small introduction, it's a neurodevelopmental disorder characterized by deficit in social communication and interaction and presence of repetitive restrictive patterns of behavior, interest, and activities. This is what the child comes to. All of you by now have seen enough children to know how a child with autism presents. Next slide. So we'll see them. So it is 1 in 60 per 1,000. We have already have this data, so I will not go through this. They say boys are more affected than the girls. The IQ varies a lot, but they say 2:1 can have severe cognition disorder, 4:1 can have normal cognitive dysfunction. So this is how the autism, and over the years, this has increased a lot. What they really believe is true increase rather than just getting more easier diagnosis is not anymore accepted. Next slide. So these are the risk factors for you from antenatal, which have been, but none of them have really proved to be of any use. That is environmental toxins, which are talking about nutritional factors, that is, folate, vitamin D, iron deficiency. Why this is useful is not just for autism, otherwise also to have a healthy child, we can have them, these nutrition and environmental factors can be really controlled. Medication, if they are valproate and SSRI are associated, and of course any immune deficiency in mothers, but none of them are really true. Next slide. So we have some more, of course, that's the same, the gestational diabetes. These are all probable causes, but nothing of evidence-based research have come out with the cause. And of course, genetic causes there, which is, and epigenetics is what now being implicated. The genes, maybe even that is not really known. There are multiple genes, which I don't even want to list. And then they say how the environment can change the gene pattern. That's what is very important for us to understand, to provide environmental support to these children to bring out the best in them. Next slide. So persistent in, what is, we have talked about, so persistent deficit in social communication and social interaction across multiple contexts, current or by history, is important. Deficit in socio-emotional reciprocity, that is back and forth communication. Deficit in non-verbal behavior used for social interaction, like gestures. They don't use gestures, they don't make eye contact, that is a non-verbal behavior. And a deficit in developing and maintaining relationship. They don't recognize their parents, they don't recognize their caregivers, they are just, anybody and good for them. So that is, again, one of the major deficit in these children. So they ask the parents, they say, yeah, he says Amma, but she doesn't know I am Amma. And they say, Dada, that's my father. They don't have relationship, and emotionally they are deprived. Next slide. So the clinical feature is not just delayed speech or language, but lack of meaningful communication, which I just told you, uses fewer or more gestures, does not respond to pointing, repeats words and phrases, does not, pretend play is not there, gives unrelated answers, and a very robotic speech. They will often speak like the computer words, and they will talk in a very flat tone. They don't have these prosody which we all have, and does not understand jokes. Or as they've grown up, they are very literal in their meanings. They cannot understand human beings. So that's such a disadvantage. So that is the main features of the autism children. Next slide. Social, I told you, not responding to name by 12 months, avoids eye contact, prefers to be alone, and does not share his interest with others. And interaction is often only need-based. They'll come to you if they want something. Otherwise, they don't bother. And flat facial expressions, they don't have all these expressions like, and does not understand personal space, boundaries. They'll go and hug children. Even the children doesn't want them. They don't, avoids resistance. It's not comfortable by others. It's not comforted by others during distress. Some of them, if they have touch problem, they hate it when they touch you, And understanding others' feeling and talking about their own feeling is one of the greatest deficit I feel, which gives, anything to do with emotional deficit really is a setback for anyone in life. Next slide. So this is the diagnostic DSM-5 criteria of a restricted repetitive pattern of behavior or interest as manifested at least in 2 of the following areas: insistence on sameness, inflexibility, adherence to routine ritual patterns, and highly restricted fixed interests that they can play with the car, wheels of the car, line it up, and hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment. They can go touch, smell, taste. So depending on what kind of problem they have, so you must have a restricted third component of the, along with social communication, this as a criteria for diagnosing autism. Next slide. Unusual interest like lines up toys, plays with the toys the same way, parts of the object, and you feel it's very organized, but the sameness and routine. Gets upset even with minor changes, and very obsessive interest. You will find, especially in 4 or 5 years, they're quite okay to go to school, but they'll talk only of dinosaurs or only of some celestial object which they get attached to and talk about it, and other children can't stand them, so they don't make friends. They can has to follow certain routines, flapping hand, all these are rocking body, all these are features of the unusual interest in behavior. Next slide. So diagnostic criteria, I'll not go. Symptoms, causes, clinically significant impairment in social communication, occupation, other functional areas for the child. They are not better explained by intellectual disabilities or global developmental delay. A severe global developmental delay child may present to you looking like autism, but they are not, you have to see. Associated features, you can have hyperactivity, impulsivity, short attention span, aggression, injuries, temper tantrums, unusual sleeping and eating habit, unusual moods and lack of fear, unusual reaction to things like sound, smell, taste, look, feel. All these are clinical associated features, and you have to take a good history with undertaking all these areas. You have to see because in management, you have to manage all this along with the other features. Next slide. Right. So this is the DSM-5. You can see the aggression, ADHD, social anxiety, OCD, all this develops later. Next slide. This is just to give you. Now we had a 3-year-old boy who presented with delayed speech, an uneventful birth history. They normally have a good birth history. The gross motor was all age appropriate. Fine motor also, this child had a good Spencer card, good tripod grasp, and obeys one-step command inconsistently. That means at 3 years, you could follow one step. When does a child follow one-step command? At 1 year. Put it on the table, close the door, give me the ball should come at 1 year of age. By 2 years, they should follow 2-step command. Give me the ball and close the door. By 3 years, they'll follow 3-step command. Close the door, give me the ball, get my keys. 4 year, 4 steps. So that is a receptive language for pediatricians to know. Next slide. So he follows only 1-step command inconsistently. And expressive language, he repeats what the parents say. Can recite, I told you, right? He says A to Z, 1 to 10. Social name call response is need-based. If you call him, he may just turn around once in a while. And he loves to play by himself, reciting names to himself. Functional play and very need-based. What is functional play and what is need? Functional play means The child will has a car, he'll just move it around. By 3 years, child will do pretend play. He'll pretend to be a teacher, pretend to be a parent, giving ideas, and pretend to play with as a child. So many things. So that's not there. And he cries loud noises in crowded places. He hates crowded places. Every time the parents take him out, they say it's a nightmare to take the child out. And then he likes enjoying spinning the car wheels, and occasionally he also head bangs and screams when things don't go his own way. But on physical examination, everything was normal. He had no physical signs at all. What do you think? Next slide. Okay. Now, let's understand speech and language communication. I told you is just to express your ideas, thought, speech, gestures, written, signs, all these. So when the receiver gets these, he understands. And then he understands your speech and then gives you a response. And there is the intention for it. These children don't have that. Their speech is not what they're communicating to others. They're just saying things. Next slide. I will emphasize this again and again because this is what you all miss, Okay, this help in consider a baby and their mother interacting. This is without words. This is called expresses interest in the caregiver. See the social interaction of the child, how it's enjoying the mother, Yeah, as okay. Pay attention to the caregiver, share their emotions. This is very, very important. Next slide. Takes turns, It can then, when it comes to imitation, it can do motor imitation, it can do control air, motor imitation. It goes, what is speech? Speech is your oromotor imitation, your flow of your energy of sound, which comes to you as speech, which has a meaning. It's called pattern. So now when I speak in English, you understand English and my energy is flowing through you in a very patterned way. So your brain deciphers what it is. If without air, we do not have speech, that is speech. But when it comes to language, this has a meaning and the other person should understand, or the person who's conveying it should know what he wants to say, which these children have a problem. Next slide. Okay, then how does it develop? Object imitation comes first, the child, then comes gross motor imitation. Child will do all the body movements, then imitate small movements with their hands like pointing. Then it has movement of the head, mouth, and controls. And then verbal imitation starts when the child will show you verbally what it wants to say. Next slide. So I will just say, what is the role of the pediatrician? Role of the pediatrician is next slide. Is perform developmental surveillance at every child's visit. At least do a developmental survey. Perform developmental screening using standard screening tool at 9, 18, and 13 months of age. And if there is any concern expressed, please look for greater assessment. If concerning, refer to a developmental or do a medical evaluation. If you're good at it, you can do it yourself. Follow up with the referral made and continuously take the developmental status. These children come back to you all the time. So even if they've gone to a developmental pediatrician, I feel you should ask them back when they come to your next immunization visit, what is happening with your child? How then, because they have far more faith in their regular pediatrician than they have even with the stranger like developmental pediatrician who will tell them this is wrong, and they'll go back and get very worried and ask you back, and you have to guide them is what is right and what is wrong. Next slide. So we have a developmental screening tool called Track and Act. This is a free tool where from 4 months to 5 years, you can put the date of birth of the child on a full term. From 4 months to 5 years, it will ask you questions in the 4 domains. And the answer is yes or no. And it is a scoring, which will tell you if the child is developing normally in each of these domains or not. It's a free app which is available. You can go to Google Play Store. You can download this app. It's available in Tamil, Kannada, Hindi, and English, for parents to use. But only thing you have to make sure that the answer is the child does it 70% of the time. Day before yesterday, once he looked at me, you pointed yesterday, doctor. Once in a way he does is not the answer. Out of 10 times you call the name, he should look back at least 7 to 8 times. He should give you a response. And that is the correct response. And this is a screening tool. Pretty good, sensitivity is good. We have had more than lakhs of children and nobody has complained about this. And if the child fails in this, surely your Dasi and all, it will fail. It's pretty sensitive too. use it. And for IT savvy people, we made this because you youngsters are very IT savvy. You can have this in your mobile and do it wherever you all are. No, that is the reason for developing online screening tools. Otherwise, there are plenty available by Dr. Nair has done it, and the ages and stages questionnaire is there. There are many screens. If you are comfortable with those, please use those also, but use something to detect early. Next slide. Then once you have this, we are suspecting, you can do the MChat follow-up. These are questions, 20 questions. I'm not going through this. It will give you an idea and you can suspect whether this child is going to the autism spectrum or not. This again is a screening tool, but pretty good and available in many languages, in Indian languages for you to use this. Next. So what happens at the developmental center? Now you have done this, you have come, we still have a diagnosis to go. Next slide. So when you suspect all this and you say, yeah, this child looks like it is at the risk of developing something, we do a very detailed assessment. Assessment in what? We do it in receptive language, expressive language, imitation skills, peer interaction, fine motor, intelligence. All these are areas which affect learning. And you have to know where this child is in each one of these areas for you to understand and come, because as I told you, it is sequence. And because wherever the child is short of in his development, you have to start developing the child from where it is. Next slide. So this is what is a criterion-based tool which we all use. You can see this. This is receptive language, expressive language, labeling, play, peer interaction, self-help skills, visual perception, imitation, fine. Now this child is. This child is, I think, 3 years old, but you can see he is functioning. This level is between 6 to 18 months. This is 18 months to 3 years. This is 3 to 5 years. You can see how low this child is functioning. His receptive, expressive, his labeling skills are even less, hardly like a 6-month-old child. At best, you can give this child around, say, 1 year of age, 1 year, 2 months. So because you have to start, when you do an intervention, you have to do it in all these areas. And you must know where the child is because you do what is called a zone of proximal development. That means this child will have to be programmed from here for the next, for him to achieve this set of milestones. So a good assessment in this, what we do once you refer this child to us, so that the person who is doing intervention has ideas as to what kind of intervention is required. If you don't know that, we do randomly something, which of course the child will show some improvement, but and this also helps us to track improvement, because after 3 to 6 months, again, when you reassess, if you know the child is improving, then all these areas, green in this area means the child has achieved the milestones. Orange means it's emerging. Sometimes it will do, sometimes it will not do. White means the child does not do it at all. So this is very good for progress, for progression as well as assessment. Next slide. So this is how the report will be generated for you, that the child is in receptive languages. We also generate, besides visual, which parents, we find it very easy to counsel the parents when we give that visual report, but the same thing is even generated as a report in the profile. It's called the SCOPE profile. SCOPE stands for Social Communication Play in Education. That is what the whole report comes to you. So you easily know where your child is standing, how severe is the problem, which are the areas which are severely affected, how are you going to counsel the parents, how will you start an intervention. So all this, it becomes pretty easy. Next slide. So the management, of course, is not my point, but you have to have a very holistic management addressing all these areas. Otherwise, it's difficult to get good prognosis in this child. Next, I think I've finished. Yeah. So we use this model, which why we use this assessment and all in the, one of the things which we realized during the pandemic was when we use a natural developing behavior model at home based activities, parent mediated program is what we practice in our center. The therapist only helps the parents to do the activities in the house by doing all, the intervention is based on all these things. This is not the topic for today. Chaya is talking on intervention. So I think I'm done with the assessment. And all in all, I want to say is social-emotional milestones are very key to monitor. You have to know where your child stands to make a good assessment, and the clinician should be extremely sensitive. And when Kritika was talking about inclusion, how are we going to do it if we don't even monitor milestones? So thank you very much for giving me this opportunity to tell you all the way one physician or a pediatrician can go about in his office practice as an approach to autism spectrum disorders in children. Thank you.
Thank you so much, ma'am. That was a detailed talk on how to. So without, let me introduce the next speaker, Dr. Chaya. She's director of Asha Center for Autism and Intellectual Developmental Disorder. She's trained in evidence-based practices and special curriculum for autism from University of New Mexico. She's owning a lot of position in IAP developmental and behavior pediatrics chapter. She's a recipient of UT State Commendation Award from Chandigarh. So let me invite Dr. Chaya to go ahead with her presentation on early intervention. After diagnosis, what to do? It is intervention. It's all yours, Dr. Chaya.
Thank you, Dr. Kirtika, for the nice introduction. And Nandini ma'am has given a beautiful presentation, and it's always a pleasure to listen to her and to learn from her. Really lovely being associated with her. And at the onset, I would like to thank ComHAD and Dr. Ravi, Dr. Paramesh for having this session today. And Dr. Yashwant Patil sir also for honoring us by being present for the session, and all our seniors, Budantar sir, and everybody at ComHAD. So thank you for giving us this opportunity. And without taking any further time, as you know, Nandini ma'am would be the best person to speak on intervention as well. But since the topics had to be divided, so I'm going to be speaking on interventions. And I will not be going too much into intricacies of the types of interventions are there, but the basic requirements, what the doctors, therapists, and parents should know, that is very important. And the main thing, as ma'am also mentioned, that what is needed to help children with autism, it is not only science, but it is also the concern for the child and the family, the empathy you feel for the child, the compassion to work, because working with the children with autism is not a one-time thing. You have to be associated with them. You have to do the hand holding, and you have to keep on guiding parents, because many behaviors are going to change and many needs are going to come up on the way. There should be a pure intention to help the child and family. So I think therapies and interventions should not be commercialized, but they should only be done by people who actually want to bring about a change in the child and the family's life. There should be a lot of love, but firm discipline, assertiveness, and a lot of perseverance and patience, not only amongst the doctors and therapists, but amongst the parents as well. So as ma'am has already mentioned about the signs of autism, to understand how do we work with children once we have diagnosed them. Now let us understand that for children with autism, social interaction is not as rewarding as the environmental variables are, and hence they are more interested in non-living things rather than the human beings around them. So these children are not drawn to faces, voices as other children, and they usually actually learn language and imitation skills and social skills from watching the humans in their environment. But children with autism are not able to do this. And as madam explained about the neuronal plasticity, they miss out on this opportunity to learn. Autism affects the child's ability also to understand and interact with their environment. So what should be the mission of the developmental interventionist? It should be to try and enter the world in order to improve and increase the communication and relationship skills of the child with the world around him. As we know, the early signs of autism, the attachment and the emotional effect with the parents, with the mother, with the caregiver is absent. So one has to work towards the social and the communication skills also. So parents are a key element in the interventions, not only because they spend most of the time with the child, but they can also help generalize the new skills, and also because we know that a well-informed parent, he understands a better prognosis than, parents roaming about to multiple centers and multiple people and getting confused. So it is important that you settle down in one place and understand what is required to be done with the child. So the richness of a multidisciplinary setting, so multidisciplinary setting and interdisciplinary functioning, these two remain the mainstay for working with children with autism and related disabilities. And the center must have developmental pediatrician working with the team of professionals, because they are the ones who coordinate with all the therapists, with the parents. They help lay down the plan that is going to be done for the child. They take care of the medical problems. They take care of the other things that the parents are not able to understand. A lot of counseling is done by the developmental pediatricians. So it is very important that the multidisciplinary team consists of a developmental pediatrician and along with a team of special educators, psychologists, and other therapists who are actually trained to work with children. And over here, I would also like to mention that parents, grandparents, siblings, teachers, they all play a very important role, and they should attend some sessions to understand what is going on and what they can do to help the child improve in the social and communication skills. So what constitutes goals for an early intervention program? So first, of course, is the interdisciplinary diagnosis. By this, I do not mean label the child, but the interdisciplinary diagnosis is when the therapist and the doctors sit together and what they have seen and what they have observed in the child, and they have noted down the strength and the weaknesses of the child. And then they discuss that what are the initial skills which are deficit that need to be worked upon, and then the short-term goals and the long-term goals to be laid down. The design and the implementation of the specific intervention program is very important. And it is also important that we involve the parents while the program is being laid down. Early intervention programs can make big difference and bring positive and permanent changes in the child. And as Nandini ma'am mentioned it, even in my practice over last many years, I tell the parents that please bring the child before 3 years of age. I tell the pediatricians, please refer the child before the age of 3 years, when the neurons are ready to learn and get molded and make better connections for social and communication skills. So some of the specific early intervention programs, they have demonstrated their effectiveness in containment and extension of the core symptoms of autism. And I'm just not quoting this, as a theory over here. I have many children who were referred from prime institutes as autism, and they were already on many medicines, including clonidine at the age of 2 years. And we worked with the child and we realized that, these are the children coming to us early. They could do without medications, and early intervention, one-on-one interventions, and with appropriate interventions, these children are going to school and doing well in their studies and communicating well with the parents and with their peers. So these interventions require highly qualified, experienced interdisciplinary professionals. But again, I repeat, and again I repeat, that there should be enough empathy. If there is a therapist or there is a doctor or anybody who is not interested in working with the child can feel it, that the child is not wanted. The child can actually feel that the therapist wants to help me. So until and unless the child does not allow the therapist to treat him, to work with him, then the therapist will not be able to work with the child. So the first and the foremost goal stays to develop a rapport with the child. So the therapist must develop a good rapport with the child, and the child should feel happy working with the therapist. Only then the learning journey begins. The end goal is not only to improve the child's ability, but it is also a question of the quality of life and well-being of the whole family as such. Again, I would like to mention over here that ignorance about presence of autistic signs on the part of family and sometimes the health and education staff also, they limit the detection and early diagnosis. So that makes it difficult for the parents to take a decision. Even if they have been told, they might go from pillar to post, asking for help and asking for second opinions on how they should move ahead. And as ma'am mentioned, they might go in for alternative therapies also. But they must understand that appropriate interventions remain the mainstay. As you can see this slide, which shows us the normal development between birth and up to 20 months of age. So here you can see that between 8 months to 15 months is the actual time when the signs of autism start to appear. And something like, the task cooperation with the mother, the conversational babbling with the mother, the symbolic play, all these things start disappearing in these children. Or if they have not appeared, it becomes more obvious that the child is not playful and is rather very quiet. And sometimes the parents or a doctor may say that ye bahut acha bacha hai, remains quiet, sits quietly, does not trouble anybody. So even then we should become alert that why this child is not interacting with people in the environment, and get a hang of that. So all of these early symptoms can occur with variable intensity and varying time of their appearances. So I will not go into detail about the signs and symptoms of autism, ma'am has already mentioned, but only to understand that for the early intervention model to be successful, it is important that the team assesses the following things. First, you must assess what is the child's social relation ability. If the child does not have eye contact, if the child is not giving an emotional reciprocity, you cannot sit and teach academics to that child, even if the child is 4 or 5 years old. So it is very important that we begin from basics. Whatever the age the child is coming to you, even if he's coming at 6 years, 4 years, 8 years, you have to start from the basic. If the child does not have eye contact, if the child is not paying attention to you, you must work on the attentional skills, must work on instruction following. You must help the child to become, have a good adaptability in the environment, in the surrounding. Only then, the child will start learning. So this is something that you have to prepare the child to learn. So these readiness skills have to be there. One must also assess the communication and language ability of the child. There are many tools available, and before we start working with the child, we must know what is the level of language of the child. Very commonly, the pediatricians can also use the Trivandrum less the LEST that is available 0 to 3, 3 to 6 years, or we can also use the reels. We have the extended reels as well, and it gives a very good idea of the receptive language as well as the expressive language. Many times, parents, they directly take the children for speech therapy. Now, over here, very important thing to understand is that if your child has a poor receptive language, does not understand anything, how can the child develop expressive language? So one must work on the receptive language, and one must know what is the level of the receptive language of that child. Usko kitna samajh mein aata hai, what is the understanding level? And then after that, they have to go on to the expressive level. So it's very important that we note and document these things down before we start working with the child. Because if we start working without documentation, we don't know where we are going. We don't know what our goals are. We don't know what our aims and objectives are. So it's very important that we do all of these things. So next comes, about the play skills. Of course, play therapy, play skills remains the mainstay of teaching any skills to the child. You cannot force the child to just sit in one corner and one place and learn all the skills. So there has to be a free play between the therapist and the child, or between the mother and the child. So this free play is the thing which develops a rapport, builds an affection between the two people, and the child learns to enjoy the company of a human being rather than an object. So it's very important that using play skills, we develop these. And of course, we have to see the behavior flexibility of the child. As we know that in autism, the children become very rigid and they have some repetitive behaviors. So mothers may become very frustrated that For example, if I show them and if I tell them that this is how you have to do it at home, the mother goes home and then she says, no, the child does not play with me, the child does not listen to me. There comes the behavior intervention on how to get the attention of the child, how to put the incentives and the rewards in front of the child so that the child feels motivated to do these things. So these all things remain the mainstay of working with children. Now coming to the models, yes, this part is very theoretical, and many types of models, intervention models are available. For example, the ESDM, the relationship development intervention, RDI, flow time, then the teach module is there. ABA ma'am spoke about just now, the skirts is there. So all of these models, you do not have a fixed pattern of working with the child. It all depends on how good you are developing a rapport with the child, how well you are able to teach non-verbal and then verbal communication to the child, how well you are able to take attention of the child, and then improving these basic social skills, how you are able to move ahead gradually to the other next levels of his skills and his education. So the early intervention models, they can help promote development and produce significant and lasting improvement. And this has been researched a lot, and these also improve the individual understanding of the social environment in which they live. The effectiveness of these programs and improvements experienced by children with autism in terms of their IQ, language, and visual spatial abilities have also been shown. One thing I would like to mention over here, that whenever we start working with children, we must know what is the hearing level. Because if we start working with the child without doing a hearing test, we don't know whether the child is able to hear us. And then all the efforts, all the time, money, effort of parents also goes to waste. The efforts of the therapist also go to waste. So it's important we get a hearing test done, because hearing is not an all or none phenomena. Hearing may be very mild in one or both ears. Children sometimes may have some auditory processing disorders also. And despite their hearing being very good, the sensory processing may be troubling them, and they might not pay attention to the sounds that actually they need to listen to. So it's very important that we also get a visual examination done, because visual acuity also causes problem. If the child is not able to see properly, will not be able to enjoy what is happening around them. So intervention in autism has to target the child, the family, the child's environment, and also like they say that all these are the actors in the child's environment. Grandparents also have a very, very important role to play. So in addition, it must provide the family with the attention they require, because parents find it very difficult to learn what we are trying to teach them. We must do the hand holding. We must make them explain again and again, number of times. Even if they have not understood, we can write it and give it to them, that what is the kind of play they have to do with the child at home and what are the other intervention. So one must also keep in mind, children with autism, they experience an evolution. We have seen their behaviors change, their sensory processing change. For example, today the child is showing some temper tantrums and head banging. With some interventions and behavior interventions, a certain behavior might disappear. The sensory problem might disappear, but it may reappear again after 6 months or 10 months or after a year. So the behavior patterns keep changing. The sensory processing also keeps changing. So it's very important that we keep a look at what evolution is taking place, what environment the child, what is disturbing him in his environment or not helping him to move further, and then re-evaluate, replan, and then move ahead. So based on all of these things, it is necessary to keep in mind the following principles of intervention. One, that the program should be flexible. It has to be tailored to a child's individuality and uniqueness of the family as well, because sometimes the parents may not be able to come to the center daily. Sometimes the mother is working and maybe they want a help from home. Each child should be given a cognitive, behavioral, environmental process, and the intervention has to address the child the family and all the people in the environment, and it has to promote the welfare and quality life. It's not just teaching about social and communication skills. The American Association of Pediatric also suggested that there should be at least 24 to 25 hours of one-on-one interventions in a week, and it's not possible that a therapist does these throughout the week. So it is important that mothers take over that role, or any caretaker in the family who is well attached with the child, to take up that responsibility. So there should be a high therapist to child ratio, either 1:1 or 1:2, and then at the next level take the child to the group therapies. The program should be individualized, I already said. Now, ongoing program evaluation and monitoring should be done by the developmental pediatrician. Whatever curriculum, whatever short-term goals and long-term goals are being planned for the child, they must emphasize more on the attentional skills of the child, the play skills of the child, the imitational skills, and the social interaction, because these remain the basic foundation skills. And if the child is doing well in these skills, we'll be able to learn further. The teaching environment should be, good adaptability for the child. And, we must have some backup ready. If the child is not ready to perform something, not ready to learn something, there should always be a backup that will help the child to develop a rapport with the therapist. And close monitoring is very, very important. These programs mostly are center based, but when parents are staying far and they do not have access, they can also be home based. And in some countries, they are doing very well with the school based programs also. Of course, the age of the child should always be kept in mind as well. And these are some theoretical early intervention models which are available online. And some of them, some of them like the floor time and the RDI, they do help the children, but the alternative therapies that are available may not actually help the children, but they may actually, waste the time of the child. As Nandini ma'am mentioned, that before 3 years of age, the neuronal plasticity is very important, and the children must get appropriate interventions at that time. So it's very important that without wasting any time on the alternative therapies, the child should start with the one-on-one interventions with the therapist. Some interventions are based on communication based intervention, or they are based on the sensory motor interventions. Let me mention over here that all children with autism do not require sensory motor interventions, although we have seen that at some level sensory processing impairment is there. Some may be very mild, or some may be very severe in children with autism, but then it does not have to be totally sensory based intervention, and rather a combination of these interventions adapted to the need of the child. It should be need based also. The child will do well with that. So just a few words about the ESDM. It just strives to strengthen the reward value of the social interaction. And as Nandini ma'am had mentioned about ABA, that, it helps to just break down the task and teach the children to pick up on those tasks and develop a rapport. And it seeks to reinforce the desirable behaviors. That is more important. Whether you do ABA or you don't do ABA, it is very, very important that the positive and desirable behaviors are reinforced, and the undesirable behaviors, they are ignored and not given too much of attention. So I think this brings about a more understanding in the child. So now coming to the last few things that I'm not going to talk in detail about each of the type of intervention module, but the intervention in a child with autism is mainly based on promoting a better adaptation to the social environment, social and cultural environment. That is more important. And the early intervention module should be selected not only on the basis of the child's age, but also on the basis of his abilities and skills. Like so many times we have a child coming to us at age of 10 years, and the parents bring the whole school bag and books and everything, that ma'am, please help him, his exams are coming. But if the child does not know how to write A, B, C, D alphabets only, how can he write big answers and paragraphs? So we tell them that, whatever program we make, it is going to be as per his skills also. If he doesn't know how to write the alphabets, he's not going to be writing paragraphs. So we have to begin from the basics. So the domains of management includes everything. Very important for parents to know that it is a big task for the multidisciplinary team with the developmental pediatrician and the therapist, psychologist working. It's a big task that you have to take care of so many things in management of autism. It's not only about the social and communication core features, but it is also about the comorbid conditions like ADHD, anxiety, sleep problems, and then helping the child develop the school readiness skills, and then helping him with the inclusion in school, then helping to develop a proper curriculum for the child, getting the provisions from the government, and as they are growing, helping them to understand about the sexuality, and then getting the proper vocational training for them. So the not only the hand holding has to be there, but it is a big task for the team as well. So as I end my presentation over here on the interventions, this is this is a video that I have taken outside my house only. So as in the first video, you can see that there is this butterfly which is flying, and it's flying little higher. And the other butterfly that you see did not move at all. I went very near. I took the camera, the mobile very near, but the butterfly just decided not to budge. I went inside the house. I came out again, and I saw the butterfly still sitting there on the same leaf. But at that time was preparing to fly, rubbing the legs and just wavering the wings, and was just about to fly, but it was there for so long. So the message I wanted to give from this is that a child is like a butterfly in the wind. Some can fly higher than others, but each one flies the best it can. So why compare one against the other? Each one is different, each one is special, and each one is beautiful. That is how our children are. So we should not compare them. These are just some few photographs of our lovely children and the smiling faces of our families. And this is the team that we work with. These are some programs that we have done, some in collaboration with IIP Chandigarh, some with neurodevelopmental chapter. So it's been a growing, it's been a learning experience growing with IIP also. And I would like to thank not only the team at our center, but the Indian Academy of Pediatrics and ComHAD as well for this learning experience. So thank you very much. And I hope I have done some justice to, the presentation. Thank you very much.
Thank you so much, ma'am. Both Dr. Chaya and Dr. Nandini. It was such a great learning experience. Summing up for all the participants, what as pediatrician we can do, it's not like wait till 4 years of age for all the DSM-5 criteria, social communication deficits or sensory deficits, rigidity to come in. Rather start looking from 8 months onwards. As pediatrician, we start looking for developmental surveillance during vaccination visit, during general visit. What are the things we have to look for is a child responding to name? By 7 to 10 months, is a child responding to his name? When we call the name, is a child responding? Second is a child is able to follow our pointing. When something is pointed at, is a child immediately responding by 10 to 12 months, looking at that. By 12 to 15 months, has a child started pointing to needs? If they want something, are they pointing with their finger and are they asking for needs? And when it comes to 15 to 18 months, are they pointing and sharing their interest? And very important in language development is not how much they talk, as Dr. Nandini said, it's not 1, 2, 3, ABCD. Are they understanding appropriate for age? By 1.5 years, are they able to follow the one-step instruction? And if they are talking, are they talking meaningfully? How is their play? How is their imitation skills? By 1.5 years, is a child able to imitate the play action? Is a child able to imitate hi, bye, gestures? And by 2 years of age, is a child having pretend play? If in developmental surveillance, if these children are not having this, immediately refer the child to a developmental pediatrician or to a good team where a proper assessment can be done. as both the speakers spoke, assessment is important because it's not that from the child's chronological age, the therapies are going to be started. It's from the child's functional age. If the child is 3-year-old but functioning like a 10-month-old child, the therapy is going to start from there. And it's not only the language, play, and the social skills. As a team, they are going to look into the child's cognition, the child's visual perception skills, the associated comorbidities. Everything has to be looked at. And autism is a diagnosis in evolution. So as Dr. Chaya rightly said, it is in evolution. So at every age, there is one particular thing to be addressed. It could be sleep, it could be behaviors, it could be education, might be in adolescence, it's sexuality. It is like whether the child has to choose vocational training or it has to go to a mainstream school. So if so, there isn't a developmental pediatrician. If it's from a small town, make sure that the parents go to a big town and get an assessment, get a proper guidance from a developmental pediatrician, and then continue the therapy. And when it comes to therapy, it is a multidisciplinary team which is going to address it. And as rightly said, it is not the knowledge, it's with how much empathy that the therapist is going to do therapy with the children. And it's how much the parents are going to be empowered. It's not only the parent, it is the whole family, because it's not only the mother who is going to take it. Is like the mother should have a supportive, nurturing environment. So how that is going to happen? How as pediatrician, we are going to empower the family itself to handle the situation. That really matters. There are a lot of different developmental models, but everything is going to be unique to the child. It's not like one model works, it works for all children. So a multidisciplinary team is going to decide which model is going to work for the child and whether it is one-to-one intervention. And to have a consistent intervention, the parent has to make it sure that they are going to do it at home also. So how much the therapist and the pediatrician and the developmental pediatrician is going to help the family to be empowered to handle that at home. So on a whole, it was a great and wonderful presentation. Let me look into the questions from the audience. So 2 questions to the speakers. One is, now in this COVID situation, a lot of screen time, and many parents contributed to, like, okay, have shown a lot of screen time. The child at 2 years, not having all these early signs, like not following pointing, not responding to name call, not understanding the language, but saying 1, 2, 3. And they ask, doctor, is it mainly due to screen time? So to share their light, is it only screen time which caused it, or how the parent should be convinced? Dr. Nandini?
Madam is there? Nandini ma'am?
Yeah. Kritika can herself answer all the questions. I think, well, screen time does not cause autism, by the way. I mean, if the parents are thinking that that is the reason, well, the thing about the screen time is it's very addictive because it gives you reward very easily, quickly. So the children are, so once you can reduce the screen time, take away the screen time, engage the child in human interaction, which is what is lacking in autism. So if parents start taking interest, and we find that it will improve the signs and symptoms, and it may not be, but that does not mean a child with autism on a screen time will become worse. Yes, because it's not having a human interaction. What is our social skills we are talking about? What does the screen does not give is only social skills. It can give you a whole lot of programs. You know, you can get all sorts of intervention. You can do this in the screen. But what is lacking, and what do we want in our lives as human being is social interaction. We interact with parents, with the teachers, the peers, with anywhere they go, with their siblings. And that's what is the problem with the autism. So the screen time. Yeah.
Can I add one point to that? So, for the audience and for people to know that the neurons, when they are developing in the early period, they have the capability of developing 1 or 2 languages at the most. So what happens is that in the early infancy, at this time, when the screen is introduced to children, to infants and to toddlers, what happens is that the neurons are, in the stage of imitational skills. So they are learning what they are seeing on the screen, but they are not getting a reciprocation back that they get from the human beings. So the social reciprocation thing is getting cut off totally. The neurons are only picking up the words that they are listening from the screen. So they are not able to develop a fluency of language, and it is the neurons which were actually supposed to pick up the language, the native language that we call as the mother tongue, the native language spoken at home, because those neurons are not stimulated. So again, the process of use it or lose it. So these neurons start dying down, and they are only interested in watching the screen and responding to the screen. The other thing we also know by research is that children, when they watch screen up to the age of 3 years, they find it very difficult to, in the transition on what they are seeing on screen and bringing it to reality. So they are not able to differentiate it. They do not have the ability in the neurons to differentiate it. So hence they start living in that world of fantasy. And many parents come and say that he talks like Peppa Pig, he walks like Peppa Pig, and all of those things, because he is learning from that imitation. So definitely the language, the expressive language definitely gets hampered over there. And that's why we advise that screen should not be given to children. Like today Dr. Dalwai was mentioning that for last 10 years he has been writing, and same here, for last 10-15 years we have been writing on the prescription and giving to parents that please do not introduce screen to your child before the age of 3 to 4 years in the home environment.
Rightly said. Screen time is going to hamper the language development, and children who are at risk for developing autism will show the features. It's not that screen is causing autism. The children at risk become more worse. And now another question to Dr. Chaya. Like, there are a lot of parents who come to the clinic and ask, like, can we try gene therapy? Can we try intranasal oxytocin? Can we try hyperbaric oxygen, GFCF diet? Dr. Chaya, I want your valuable input on this. What should a pediatrician?
Hi. Hello. I think, is it us or everybody else?
Nandini ma'am, am I audible?
Yeah, I think there was some problem. Hello.
Okay.
Hello.
Yeah, I can hear you.
Yeah, Kirtika, can you hear me?
Yeah, Dr. Ravi, I can hear you.
I think
You
something
want-
happened because I could see all the screens frozen.
Yeah,
Can you just,
everything had
I think
frozen,
everything
yeah.
is something to do with the Zoom itself, because all
Okay.
the photographs, everything disappeared. Can you please repeat the question, and so that Dr.
No,
Chaya can answer?
I heard the question. I heard the
No,
question.
for the
I'll
benefit
answer.
of everybody
Okay.
else. Yeah.
Okay.
So, to a pediatrician, the parent comes and asks, they are already in some therapy, they are going for therapy, but every parent wants miracle in their life. So they come and ask, like, there is gene therapy, there is intranasal oxytocin, or camel milk, can we give the doctor? Is it that recommended? As a pediatrician, what a pediatrician should say when they come and ask these questions to a pediatrician?
Okay. So Kirtika, let's go, stepwise. So regarding the diet, let us understand that, there's been a lot of research, and in general, they say that GFCF diet, it does not help every child with autism, and we should be very, very, selective in advising such things. In fact, I myself do not advise any GFCF diet to children. But of course, at the same time, children with neurodevelopmental disorders may have some food allergies. So in case they have food allergies, then definitely we must guide the parents for that. But just because they have heard from somewhere that GFCF diet may help, I do not think we should advise these things to parents and to families. Children need nutrition, they need supplement, they need a good healthy diet. Already children with autism are picky eaters, and sometimes they have food fads. So we should be very careful about what we are advising. Also, there's been a lot of parents keep asking, that if should we give sugar to our children, and will sugar cause a problem, So, we tell the parents that in general, if you feel that giving sugar is making your child hyperactive, you may control the child on that. But we are not going to advise you that you give more sugar or you give less sugar, because there are no researches which say that sugar is causing hyperactivity. Coming to the camel milk, we don't advise camel milk, but there has been some very minor research papers which say that camel milk has helped. I do not believe completely in that, because I think along with giving these kind of diets, we are stimulating the neurons of the child. We are interacting with the child. The social and communication skills are definitely improving day by day. So we cannot say that the diet or the camel milk is actually helping the child. That cannot be true. So it is more important that we do the one-on-one intervention and teach the child about the social and communication skills. Secondly, coming to the intranasal oxytocin, there are a lot of clinical trials going on, because oxytocin is something which is released from the hypothalamus in the brain, and we know that it activates, and there are some positive hormones which are released. But at present, I do not think so that there are good researches available which actually confirm that intranasal oxytocin can help. Although the clinical trials are going on, whether intranasal oxytocin will help in improvement of the social functioning for the child and will improve the social interaction. So some research says that, if the child already has social impairment, it is not going to improve that. But if you know that this child is going to have autism, then you may give, which I don't think is true. We know that children are at risk of neurodevelopmental disorders, but we cannot say that this is a child jo aage chal ke isko autism hone wala hai. So I don't think so we should advise these things to children. Gene therapy is, I think, a very far away thing to even think about, and we should not fall in trap to these things, to stem cell therapy, to gene therapy, because we know that parents may spend lakhs of money and still be nowhere. And it's best to go to a multidisciplinary team and start with the one-on-one interventions, where the social skills will be taught, the communication skills will be taught, and then gradually the child will be taken to the level of academics also. So this is the mainstay. We should avoid the alternative therapies.
Thank you so much, ma'am. It was so clear. It was a wonderful presentation on the whole. Let me ask the organizers to give a completion talk. Thank you so much, ma'am. Thank you so much, both the speakers.
Thank you, everyone. It's been a wonderful session. It's almost an hour and a half, and I can still see there were around 55 delegates still being on stage. So it's excellent. Thank you very much, Dr. Nandini, Dr. Chaya Prasad, and Kirtika, as always, thank you for your enthusiasm and helping us to run the show. Thank you. Dr. Ashwant Patil, Dr. Priya Shivalli, and Dr. Prakash, thank you very much, sir. Thank you, everyone.
Good night, everyone.
Good night.
Good night.
Nandini, ma'am.
Good night. Good night, Chaya.
Good night. Thank you so much, ma'am. Pleasure interacting.